I am Dr. Kewal Kanabar. I am an assistant professor in the Department of Cardiology at UN Mehta Institute of Cardiology and Research Center. And I'll be discussing the approach to a patient of refractory heart failure. So, the case that I'll discuss is a 45-year-old young male patient, known case of DCM or dilated cardiomyopathy, known since the last 5 years on medical treatment. He has recently been diagnosed with type 2 diabetes mellitus. He has had 2 episodes of heart failure hospitalization in the last 6 months. His background medical treatment includes usual dose of diuretic, that is torsemide 10 milligram twice a day, 25 milligrams of spironolactone once a day, sacubitril valsartan 50 milligram twice a day, and metoprolol 50 milligram once a day. Now, this patient is somebody who has known DCM. Now, the patients who come to tertiary care centers are being labeled as DCM when they are found to have a systolic dysfunction in the absence of any cause. But some of these patients can have a different diagnosis. Some of these patients can have ischemic cardiomyopathy. Some of them can have infiltrative diseases like sarcoidosis. So, just a plain label of dilated cardiomyopathy is not enough. In a study that was conducted recently, which included approximately 1,200 patients, they showed that in patients who were labeled as idiopathic DCM, only 50% were found to have idiopathic DCM. Approximately 10 to 15% had ischemic cardiomyopathy, and the remaining 30 to 40% had miscellaneous causes of cardiomyopathy like post-myocarditis, post-cancer chemotherapies, post-viral infections. So it is important to know the cause of LV dysfunction because that is going to guide the treatment and the management. So when a patient who comes to me with a label of DCM, the things that I want to look are what is the patient's clinical status? What is his baseline clinical status? Remember, this patient has had 2 episodes of heart failure, hospitalization or acute decompensated heart failure. Now, the cause of acute decompensated heart failure in a known case of DCM can be plenty, and I'll discuss those also in detail. But what I want to look at is the baseline clinical status of the patient. What is the patient's NYHA class? So how symptomatic is the patient on optimal medical treatment when it does not have a heart failure hospitalization? Does the patient have a history of angina? This is very important. Although dilated cardiomyopathy, the idiopathic ones also can have dyspnea, can also have angina, but if angina is a prominent symptom, we should look at 2 or 3 important things. One is, does the patient have a valvular disease like aortic stenosis, which may have been missed? Or does the patient have something like a coarctation of aorta, which is giving rise to LV dysfunction? And another thing is very important, you should always rule out coronary artery disease, right? Next, does the patient have history of orthopnea or PND? What is the patient's exercise tolerance? And very important, does the patient have history of symptomatic palpitations, history of syncope, or history of sudden cardiac death? Another important question I would like to ask is, does the patient have right heart failure symptoms like anorexia, nausea, vomiting, jaundice, abdominal distension, pedal edema? Because if these are present, the prognosis drastically changes. Just left heart failure symptoms are manageable, but once right heart failure symptoms start, the disease usually has a downhill course. I want to ask the baseline history. Is the patient hypertensive? Does the patient have history of alcohol abuse or binge alcohol consumption? Is there a family history of sudden cardiac death or a family history of cardiomyopathy? Does the patient have a prior history of malignancy for which he received chemotherapy? Did the patient have any history of viral infection preceding the first episode of hospitalization, which may suggest that the patient may have post-myocarditis cardiomyopathy? Or does the patient have any systemic symptoms of infiltrative diseases like sarcoidosis or amyloidosis, periorbital purpurias, skin lesions, arthritis, or pulmonary symptoms? We all know the NYHA classification. Class 1 is the patient usually is asymptomatic on ordinary physical activity. Class 2 is symptomatic on ordinary activity. Class 3 is on less than ordinary activity. And class 4 is symptoms at rest. Now, the things which I want to stress on, what is the reason for decompensation? Remember that DCM is usually a stable disease. The downhill course is slow. And the average survival in the recent studies usually lasts from 5 to 10 years. But why did the patient decompensate? One very important point, and one of the most important I would say, is that there may be non-compliance to drugs. Patients usually on medical treatment feel that they are doing much well, and that is why they stop all their drugs. And drug non-compliance is particularly a very important cause of decompensation. Second is dietary incompliance. If the patient is taking too much salt or too much water. So I would like to ask for the water intake. I would also like to ask for what is the weight. What is the serial weight monitoring over the period of last 6 to 12 months? Infections, particularly respiratory tract infections, COVID, they are all known to precipitate dilated cardiomyopathy and can lead to heart failure hospitalizations. Ischemia, another very important cause, is what I want to look at. Very important is arrhythmias, particularly atrial fibrillation, fast ventricular rate, SVTs, VTs. They all can decompensate a known patient with DCM. Alcohol use, drugs like calcium channel blockers, steroids, they can all precipitate CCVs, and these are what I want to look at for the reason for decompensation. Reason for DCM, as I've already discussed, I want to look at history of alcohol abuse, history of viral myocarditis, history of cancer chemotherapy, and a history of angina, which may suggest that the patient may have associated coronary artery disease. On the physical examination, a lot of physical examination has been replaced by echocardiogram, but what cannot be replaced by an echocardiogram is the basic examination. What are the patient's vitals? What is the pulse? If the patient has sinus tachycardia or pulsus alternans, these usually suggest an adverse prognosis. Particularly if the patient has sinus tachycardia, it usually means that the disease is far advanced. I particularly want to look at the patient's general condition, the height, weight, and the BMI, because that would suggest what is the patient's clinical status. Anorexic patient usually indicates that the patient has advanced CHF. Very important is to stress on cardiopulmonary examination, particularly examination of the respiratory system to look for crepitations or wheeze and signs of systemic congestion in the form of pedal edema, hepatomegaly, and raised JVP. These are things which cannot be given by an echocardiogram. An echocardiogram can give you a lot of things, but these are the things which we need to examine and we need to assess before we start the patient on any treatment. The cardiovascular examination, although not very important, I would say that looking for murmurs is important, but a lot of cardiovascular examination can be supplemented or replaced by an echocardiogram. A very important test, ECG, a baseline ECG and the current ECG is very important because I want to look at certain things. What is the heart rate? As I already stressed, tachycardia is an adverse prognostic marker. I want to look at the rhythm. Does the patient have atrial fibrillation? Does the patient have sinus tachycardia? Does the patient have ventricular ectopics? Does the patient have ventricular tachycardia? All these are important. Findings of old MI may indicate that this may be an ischemic cardiomyopathy. So, and also these patients can have right bundle branch block, left bundle branch block, bifascicular blocks, trifascicular blocks. What is very important is I want to look at if the patient has left bundle branch block, because that would indicate that the patient may be a candidate for a cardiac resynchronization therapy. So as I've said that I want to look at arrhythmias, I want to look at conduction blocks, I want to look at the rate, I want to look at the rhythm. Figure on the left indicates atrial fibrillation with a fast rate and can precipitate DCMP. And the figure on the right indicates that the patient has non-sustained VT. And if the patient has non-sustained VT, he may be a candidate for an ICD or a CRTD. So these are things I want to look at in the electrocardiogram. On the echocardiogram, I particularly want to look at the LV dimensions. What are the LV dimensions? LV dimension higher than 70 usually indicates very advanced disease and indicates an adverse prognosis. So I want to assess the LV function by Simpson's method. I want to look for regional wall motion abnormalities, the LV and the LA dimensions. Very important is I want to look at the right side of the heart. What is going on in the right side of the heart? So what are the RV pressures? What is the RA pressure? And what is the PA pressure? Now the workup requires certain blood investigations to be done. I want to look at the complete blood count. Remember that a hemoglobin of more than 12 is acceptable. A hemoglobin of 10 to 12, if there is iron deficiency, needs to be supplemented with IV iron, like ferric carboxymaltose. So I want to look at the iron studies with ferritin. So I'll do a complete blood count with MCH, MCV, MCHC with iron studies and ferritin. I want to look at the renal functions. Very important because they are going to be a key determining factor in the treatment that we give. So urea, creatinine, sodium, potassium, calcium, and magnesium. I want to look at the thyroid function test, T4 and TSH. A baseline troponin I or troponin D should be done in all patients. Very important is the role of biomarkers, BNP or NT-proBNP. It should be done in all patients and it should also be used for follow-up. Since the patient is on sacubitril valsartan, we cannot use BNP and we need to use NT-proBNP. So I'll, in this patient, go for an NT-proBNP. And if the values are more than 500, it usually indicates that the levels are elevated. I'll do a liver function test. Since the patient is diabetic, I'll do an HbA1c, fasting and postprandial blood sugars. I'll do a lipid profile and workup for HIV. Also in this patient, you should always look for pheochromocytoma, especially if the patient has history of hypertension or resistant hypertension. Now, apart from the blood workup, there are certain things which we can do. So a cardiac MRI is very helpful because it can give you an idea about any infiltration. It can give you an idea if the patient has underlying sarcoidosis, giant cell myocarditis, if the patient has an old scar, if the patient has ischemic heart disease. So cardiac MRI should be done in all young patients with dilated cardiomyopathy. Muga scan I only advise the patient to undergo if the patient is planned for a cardiac transplant. Otherwise, I won't suggest to undergo a Muga scan, but cardiac MRI should be done in all young patients with DCM, especially if they have arrhythmias or conduction blocks. Holter, I will advise the patient if the patient has any history of syncope, or if there are ectopics on the ECG, or if there is conduction block. If there is any suspicion of an arrhythmia, ventricular arrhythmias, atrial fibrillation, then I'll advise the patient to undergo Holter. Coronary angiogram, I'll advise this patient because this patient is diabetic, this patient has DCM. Coronary angio should always be done to rule out underlying ischemic heart disease, because we know that treatment of ischemia either by angioplasty or bypass has the potential to improve the left ventricular function in these patients. Assessment of functional capacity is not frequently done, but I would suggest the patient to undergo assessment of functional capacity at least once. Although cardiopulmonary exercise test or CPET is the gold standard, it is not frequently used and also not frequently available. So a simpler test that we can do is a 6-minute walk test, and it can be used to guide the treatment and also to follow up of these patients. The treatment of the patient is not limited to the patient himself, but also to his siblings and also to his children. So genetic screening and family screening is important. Genetic screening for DCM is not widely available in our country. So that is something that is something restricted for the future, but family screening with the echocardiogram and an electrocardiogram should be done for all siblings and for all of his children. So the underlying evaluation of this patient focus is basically on history, physical examination, very important blood workup, especially biomarkers like troponin and NT-proBNP, and always a coronary angiogram and advanced imaging in the form of either cardiac MRI and a Muga. And if required, we can undergo Holter and assessment of the cardiopulmonary exercise capacity, either with a cardiopulmonary exercise test or a 6-minute walk test. That would be all in the evaluation of young DCM who has had 2 heart failure hospitalizations recently. Thank you.